thank you so much for that introduction. Really, for about the last decade of my career in bioethics, I've focused on the question of social inequalities in health, so the ethical and the policy implications of social inequalities in health. So what I want to talk with you all today about is pretty far removed from the work that goes on in your laboratories, and in some senses even far removed from medicine. I am going to talk with you about a matter, though, that is of great concern to at least some health researchers, and increasingly to health policymakers, and thus I hope you'll find my being here relevant to your broader concerns. I'm going to talk with you all today about, as Dr. Werner foreshadowed, social inequalities in health, which we in the US often refer to as health disparities, but internationally these are typically called social inequalities in health, and on what moral grounds, what ethical grounds we might consider such inequalities unjust. So my specific objectives with you in the next 45 minutes or so are to describe the social gradient in health and the social determinants of health, which will give us some traction on what social inequalities in health are. Second, I'm going to distinguish disparities in health from disparities in health care. And for those of you in this room who are intimately acquainted with that distinction, forgive the redundancy, but it has been my experience over the last decade that I often have to ask even well-informed people to make that distinction because they tend to confuse and conflate them. And then finally, I'll address the question, are social inequalities in health unjust? And this question raises a host of other questions that are timely and contentious, such as who's responsible for health? The health responsibility debate that plays out in political discourse, in policy discourse, and in philosophical discourse. What sort of good is health? And should it be subject to considerations of justice? Who should be included in our health systems if we think that there is sort of, that it is appropriate to think about health being subject to considerations of justice? Who do we include in that idea? And how do we conceptualize the health system? And how do we distribute resources across social sectors if our goal is to improve population health and reduce health disparities among subpopulations? So let's get straight to business, because what I'm going to be doing over the next 20 minutes is just laying out some empirical phenomena that are the grist for our moral inquiry. So what is the social gradient in health? And again, to those of you in the room well familiar with these concepts, you might want to take a nap or read your phone. But just so that we're all on the same page, what the social gradient in health is a pattern in population health that health researchers find wherever they study population health. It's a stepwise relationship between social position and health such that each step up or down the social ladder, there's an attendant increase or decrease in preventable morbidity and premature mortality. So quite simply, more socially advantaged people live healthier, longer lives than less advantaged people. This is obviously a population phenomenon, a statistical phenomenon. There are always exceptions. So we've known for centuries, of course, that rich people live longer, healthier lives than do poorer people. As long ago as the middle of the 19th century, we had very detailed inquiries in England, France, Germany, and the United States that demonstrated that laborers and servants lived an average of 16 years, whereas professionals and gentlemen lived an average of 45 years. But what we now understand with far greater clarity and certainty is that the relationship between social position and health is not bipolar. It's just not about extremes, but it's stepwise, as I said, so that the most well-off people, if you took any population, say that of the United States or that of a particular state within the United States, the most well-off people tend to live longer, healthier lives than do the next step down. Very advantaged people, but not quite so well off. And those people live healthier, longer lives on average than do people who are advantaged, but less so, and so on and so forth. Thus, the language of social gradient. So as social epidemiologist Michael Marmot tells us, he did the Whitehall study of civil servants in Britain, which established definitively the social gradient in the 70s. He says, the lower the social position, the higher the risk of heart disease, stroke, lung diseases, diseases of the digestive tract, kidney diseases, HIV-related disease, tuberculosis, suicide, other accidental and violent deaths. So just to put a point on this, The social gradient in health is robust. It holds for all 14 major causes of death, most forms of mental disorder and disease. It extends into the upper reaches of the social ladder, which surprised many researchers. And it's foreshadowed, very sadly, in measures of children's developmental health. Okay? The social gradient in health is also enduring. It persists over time, even though the principal causes of death change over time. So as you all know, at the turn of the century, not this most recent one, but the one before, most of us died of some form of communicable or infectious disease. We now die of some, most of us will die, 7 out of 10 of us will die of some form of chronic disease. A social gradient is found nonetheless in infectious disease then and in chronic disease now. So just to state the obvious, within this social gradient are social inequalities in health. So let's look at a definition of social inequalities in health. They are differences in the incidence, prevalence, mortality, and burden of disease, illness, and injury that exist among specific population groups in the United States. Thus, a population is a health disparity population if there's a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, or survival rates in the population as compared to the health status of the general population. So what are some examples? There are many examples I could give. I will give you 2. And now that I'm standing here before you, I'm realizing it was a little bit silly of me not to use an example right in our own hood, because I'm sure there are some. In fact, Seattle has some very steep social gradients in health in King County, something that came to the sad surprise of our Commissioner of Health. But let me give you the 2 examples I have here. African American males in DC live on average 17 years less than do their white male counterparts in neighboring, not that very far away, Montgomery County, Maryland. To use an example from a country abroad, poor males in Glasgow, Scotland have a life expectancy of 54 years compared to a life expectancy of 82 for high-income males. Now, here I'm giving you, average life expectancy, but we could use other measures of health and you would see the same thing. Now, these differences in health cannot be attributed to healthcare. They're not produced by what we might call disparities in healthcare. And none of this is to say that healthcare is not a social determinant of health, and perhaps an important one, particularly in contexts like the United States, where many millions of Americans, tens of millions of Americans, have lacked or lack. We'll see what the Affordable Care Act does. We know that there'll still be pockets of people without health care. But none of this is to say that health care might not be at play in these health disparities where people have either no access to care at all or don't have access to timely quality care. But health care in of itself cannot explain these social inequalities in health or the social gradient in health, because there's an important distinction to be made between these 2 phenomena. They are distinct phenomena. So let's just spend a few minutes sorting out healthcare disparities from health disparities. So what is a healthcare? What are healthcare inequalities or healthcare disparities? Well, the Institute of Medicine commission that studied this and produced the 2003 report, Unequal Treatment, defines them as racial or ethnic differences in healthcare that are not due to access-related factors or clinical needs and preferences. It is a rather narrow definition, even of healthcare disparities, that I think if you read the report closely, even the commissioners, the members of the commission themselves were quite frustrated to be given a charge not to consider access-related issues. So many people actually operate, when they're talking about healthcare disparities, with a slightly broader definition. Let me just put this up. Differences in the quality of healthcare across racial, ethnic, and socioeconomic groups. So what this definition does, notice, is it broadens the notion of disparities to include access-related issues and to capture those disparities that afflict not just minorities, though that's vitally important, morally important, but resource poor groups more generally, okay? So, one of the ways to get at the difference between these two types of disparities is to look at their causes. So the Institute of Medicine commissioners who studied this problem suggested the following kinds of changes as being the primary ones for remedying healthcare disparities. And notice these are all within the healthcare system. Financing and organization of healthcare services. Importantly, healthcare is socioeconomically fragmented in the United States. The availability of translation services, the use of evidence-based guidelines, elimination of clinician bias in diagnosis and treatment. Those are the sorts of remedies and reforms we need to ameliorate healthcare disparities. But eliminating healthcare disparities, by either definition, by the way, the broad one or the more narrow one, will not remedy or reduce the steep, well, it might reduce, but by how much is actually an interesting question. And there have been some really robust studies done of primary care, and we can talk about this more in the discussion period if you like. And if we had a health system that was oriented to primary care, would that move the needle on health disparities, not healthcare disparities, on health disparities? And it looks like the answer to that question might be yes. But even if we had a health system with robust primary care, it wouldn't eliminate these steep social gradients in health that we find here and that we find in many other countries. And that's because the origins of health disparities lie not just in healthcare, but in a broad array of social determinants. So what are the social determinants? Well, the World Health Organization's Commission on the Social Determinants of Health used this phrase over and over again to define social determinants. The circumstances, and it is this, so the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness, which are shaped by political, social, and economic forces. Some people draw a distinction between the social determinants of health and the social determinants of equity, which we kind of see figured in there. You can imagine maybe the social determinants of health being my income, my level of education, the neighborhood I live in, the level of poverty in that neighborhood, whether I have access to food, healthy food in that neighborhood. The social determinants of equity are those broader, imagine concentric circles, those political, broader economic, social systems and forces that create and shape those social determinants of health. So what am I talking about? Well, here's a list. This slide violates every rule of PowerPoint, I'm told. It has far too many words on it. But there you get a sense. And this is really a list that I've compiled just by looking at different lists. And there's actually a really interesting debate about what gets on the list and not on the list. Some people do not include, for example, health behaviors or even healthcare. But there you'll see healthcare in addition to things like income, poverty, unemployment, income inequality, education, wealth, the built environment, the food environment, the school and learning environment, housing stock, toxin exposure, healthcare, yes, social support, social capital, social security, racism and discrimination, sexism, misogyny, political environment. Do people have do they have a voice? Can they vote? Notice that was my one trick, my one PowerPoint trick. Did you see it pop? Healthcare is just one social determinant, just one social determinant. Which among these social pathways is the most potent? Which one is the most promising as an explanation of these social gradients in health that researchers find everywhere they study population health? Well, that, of course, is the subject of much investigation by social epidemiologists and epidemiologists more generally. And there's much debate about which determinants are the most important. The wisest analyses that I have seen suggest that there's actually no single determinant is going to, be the magic bullet. No one's going to win the Nobel Prize for figuring out that it's X, but rather that the social inequalities in health are generated through this complex interaction of multiple social determinants. And these things interact, as you might have figured out, these social determinants are overlapping and interact with one another. But let me just stress to, again, draw this distinction between disparities in health and disparities in healthcare. Something we know that healthcare is but one contributor and not the major contributor. So to underscore this point, let's take a look at this pie chart. I've seen a number of these pie charts. This one comes from an article by Stephen Schroeder, who was the president of the Robert Wood Johnson Foundation for a very long time. He's basing this pie chart on the work done by Michael McGinnis back in the 90s about the actual causes of death. And there you'll see that healthcare makes up only about 10%. I think I've seen a pie chart that has healthcare at 15%. Many people, especially in the US, find that figure striking, surprising, and no doubt some would dispute it. But even if we were to say, okay, let's double it, notice healthcare is not the major determinant of health. Okay. So this is my quick and dirty way, 20 minutes worth of trying to lay out for you the empirical phenomena that give rise to the question that interests me and a few others, which is what are we to make of these social inequalities in health? There are lots of things we could talk about with regard to the social inequalities in health and their causal pathways and what researchers know and what researchers don't. And I'm happy to take those questions. I should forewarn you, that is not my area of expertise. I'm trained in philosophy and ethics, and it is really the moral questions that I'm interested in. It is enough for us to know a handful of things, that this social gradient in health exists. That's really not that controversial. It's not controversial. What is more controversial is what's causing it, but we can say there is social causation. We'll talk a bit more about that in a minute, but the social determinants of health are at work in this. We wouldn't attribute this to, as some people wanted to, drift processes. What are drift processes? It is not the case that unhealthy people, that some people are just born unhealthy. They might be quite privileged, they might be middle class, they might be whatever, and they drift down the social ladder, drift processes. No doubt that that happens, but it doesn't explain the social gradient in health. This has been studied and studied and studied. Drift processes do not explain it. So, to the question of the hour, for me, are these social inequalities in health unjust? Well, you might find it interesting to know that it's only been in the last 10 or 15 years that this question has come under scrutiny by moral philosophers and bioethicists. Health care and justice have certainly been a topic of much discussion, but health itself, the first systematic normative analysis I've ever seen on the topic and that I've ever heard referenced was done in 1998. So let me just share with you a personal experience I have. You know, when I'm talking about this at dinner parties or in the elevator, because I'm kind of a boring person and I don't have much else to talk about, it's been my experience that people, you know, in casual conversation, when they learn about these social inequalities in health, if they don't know about them already, the phenomenon strikes them as morally problematic. Something about it strikes them as not quite right, if not downright unfair. And those intuitions, those moral intuitions that they have, are often relate to the following sorts of facts, which is that this disproportionate burden of injury, illness, and disease falls on those who are already disadvantaged and marginalized. Or it has something to do with the fact that the causes of these inequalities are socially controllable to some extent, or at least shaped by society, which is to say that as a polity we exercise some control, some influence over our social, legal, economic, political institutions, policies, and practices. And sometimes there's another moral intuition operative in there, which is that we're talking about health. We're not talking about candy bars. We're talking about health, which strikes some people as a very important kind of good that maybe shouldn't be subject to this sort of disparate distribution. These are all good insights, and they are relevant to justice, as we're going to see over the next 25, 30 minutes. It's a pretty complicated argument, which a lot of people don't realize until I start engaging them in discussion about it. In fact, I spend in the fall, this fall, I'm teaching a whole 10-week course on precisely this question. So what I'm going to do with you in the next 20 minutes is try to cram a 10-week course down. So I'm just buckle your seatbelts. Okay, so where do we start? Where do we start with this? Well, you can't even begin to engage the question intelligently until you have a sense of what we mean by justice, right? And I'm going to begin with a caveat that any good ethicist philosopher would begin with, which is this. There has never been, and is not now, agreement on the nature of justice, and this book was not written that long ago. So it's the kind of thing that people like me say that frustrates people like you. But we do have a place to begin, don't despair, and it came to us from Aristotle, okay? Equals must be treated equally, Aristotle taught us. Okay, notice it doesn't really tell us that much. It's what we call a formal principle, right? It's a formal principle, which is to say that it gives us no substantive criteria by which to assess who should be considered equals. And what Aristotle was most concerned with in his writings on justice, on distributive justice, was political status, participation in the polis, citizenship, and the primary criterion he posited to assess equality was merit. Merit, as determined by such things as one's honor, one's virtues, one's excellences, as he said. So for Aristotle, justice has to do with giving to each by virtue of merit. Modern notions of justice operate on a very different assumption: to each by virtue of humanity. The idea is that justice is owed to all persons because they're persons, because they're human. Not because they're virtuous, industrious, or meritorious in some respect, but because they're human. Now, it's a very interesting story that I don't have time to tell, how we got from Aristotle's idea that justice had to do with to each according to merit, by virtue of merit, to this idea to each by virtue of humanity. But if you're interested, there's a book I can recommend that's short, extremely well written, and tells that history beautifully. And I have the citation in an upcoming slide. The name of the book is called A Short History of Distributive Justice. So, okay. Modern notions of justice operate on this sort of simple, basic idea to each by virtue of humanity. That tells us something important, but still there's a whole lot lacking. So let me show you how different moral and political theorists in the modern era have interpreted the demands of this basic principle. To each according to rules and action that maximize social utility. We'd call this utilitarian justice, and we could talk for hours and hours about what that is and critiques of it. A maximum of liberty and property resulting from the exercise of liberty rights and participation in free market exchanges. Libertarian justice. An equal measure of liberty and equal access to the goods in life that every rational person values. This is a version of egalitarian justice, and it was articulated by the late John Rawls, whose theory of justice is one to which all subsequent theories of justice in some way respond. So let me just show you some additional ways in which egalitarian, which I'll say more about what that means, egalitarian theories of justice or principles of justice might play out. To each the means necessary for the realization of core dimensions of well-being. To each the means necessary for the exercise of capabilities essential to flourishing. To each the means necessary to participate as a peer in public life. So I refer to these last four principles of justice as egalitarian in a broad sense, to mean that there's some moral concern about equality in the sense that at least some sorts of inequalities are in need of remediation, if not, or justification. So it's important to note that egalitarian theories of justice are not necessarily concerned with strict equality, okay? And certainly not in all respects. As we'll learn in a minute, theories of social justice posit that different types of goods should be distributed. So theories of justice might be concerned, for example, with giving priority to those who are least advantaged. And doing so may have the consequence of compressing inequalities. But compressing inequalities wouldn't be the overarching aim, the central aim of that theory of justice. It would be rather to help those who are worse off because they are badly off in certain important respects, okay? So to call, the simple point is to call a theory of justice egalitarian is not to suggest that those theories of justice necessarily endorse some strict idea of equality. Now, the core idea that unites these different egalitarian theories of justice or principles of justice is that all persons deserve a fair share of important goods. And here's where it gets interesting, okay? This really simple idea, all persons deserve a fair share of important goods, has at least three complex questions embedded in it. Those questions are, first, well, which goods should be subject to justice? And is health a special good? Should it be subject to justice? Is health one of the goods? How much of these goods constitutes a fair share? And who's everyone? If everyone deserves a fair share of some set of important goods, who do we mean by everyone? This idea that all persons deserve a fair share of important goods also presupposes, and by the way, this book is the book that I would recommend if you want a tour of how we got from an ancient notion of justice based on merit to a modern notion of justice based on humanity. This idea presupposes yet a fourth question, and it's really a threshold question. It's the question you have to answer first before you even get to the other three questions, which is, are the inequalities in question, and here we're talking about these social inequalities in health, are they produced by political and social institutions, policies, and practices? So, to answer the question of whether social inequalities in health are unjust, we have to ask and answer four questions. So let's take a few minutes to move through this. First, we have to ask, are they the product of what many people would just call social arrangements? Okay? What I've described as these social, legal, and economic institutions, practices, and policies. Or are they the product of behaviors? See, if we can attribute the harm or the inequality in question to a free and informed choice that a person has made, then social structure, as a phrase just to refer to that longer list of social, legal, economic, etc., then those are exculpated, right? They're off the hook. If I decided to do certain things, behave in certain ways that led to this harm, then it's not a question of social justice. But if social structures can in fact be implicated in the harm, in the inequalities, then it becomes a question. Then we're on our way down the path of trying to figure out whether the inequalities in question are in fact unjust. So we might do something like go back to that pie chart I showed you. I don't know if you noticed this. Some 40% of population health has been attributed to behavioral patterns. Which behaviors are particularly important in an era of chronic disease? You guys know. Diet, sedentariness, sexual practices, smoking, right? Are those decisions that are made by people freely made? Are they made on the basis of information? Are they made voluntarily? It's a subject of much debate. Some people come to the conclusion that they are. Some people come to the conclusion that they are not. But here's a fact to know. Even if you were going to come to the conclusion that those behaviors were voluntary and based on information and thus autonomous, and thus it still constitutes only 40% of the pie. And moreover, studies, and many studies have been done, that control for behaviors, a social gradient in health persists. So inequalities persist even after you control for the behaviors. So it's a topic of much debate. But even if you make the decision that social structures are implicated in these social inequalities in health, and thus it's an appropriate question to consider whether these are unjust, you have to consider whether health is the kind of good that should be subject to justice. Is it important enough? So if you go back this list, we might ask, well, is health a core dimension of well-being? Is it a capability essential of flourishing? Is it essential as to participate as a peer in public life? Do we need some level of mental and bodily health? When people consider this question, they'll often consider both what might be called the intrinsic and the instrumental value of health to make their determination. By intrinsic value, I simply mean that health is valued for its own sake. It feels really good to be healthy. It makes a direct contribution to one's well-being. But we also value health for its instrumental value, which is to say, it enables me to be an agent. It enables me to pursue other goods and goals that I may have. Without it, I can do far less of that, right? So when people make this determination about whether health is a special good, that's the term of art. Is it a special good? Should it be subject to considerations of justice? They look at these kinds of considerations. Third, just to go back down to our list of questions, how much health constitutes a fair share? So remember when I was talking about the social gradient in health, are we concerned only about the excess injury, illness, and disease that is experienced by the very least advantaged, by those who are at the bottom of the social ladder, at the bottom of the social gradient? Or might we find it unjust that the people just above them have a little bit less health than the people just above them, or the people above them have a little bit less health than the people above them? What exactly? How much constitutes a fair share? When should an inequality concern us? Now, in this context, we might ask the question, if we just wanted a hard measure, what constitutes a normal lifespan? If we were going to use mortality as a measure. And then finally, who counts? When we're thinking about the question of whether social inequalities are unjust, and if we've made our way through these questions, and we're of the mind that, yes, these social inequalities do seem to constitute an injustice, do seem unfair, who counts exactly? If all persons deserve a fair share of important goods, and if those goods include health, and if we mean by health something simple like a life free of preventable morbidity and premature mortality, then who's included in the everyone? Do we mean everyone everywhere? Is it a global concern? Certainly people in global health would think so. Or do we mean only people living within a particular political context, within our political borders, within the United States, say? And do we mean just citizens of the United States, just to take that as our example, because that's where we are here and now? Or do we mean people simply residing, legally or illegally? Who's included in the everyone? These are the sorts of questions one has to take up to get to an answer to the question that I posited at the beginning, which is, are these social inequalities in health unjust? And there's a quite lively debate about each stage each step along the way, each question along the way has a vibrant debate around it. Although I will add that one of the liveliest debates is in terms of the goods question. What sort of goods should be subject to justice? So with that, I'm leaving as much as 20 minutes for discussion, which is about 10 minutes more than I have to. But I'm hoping you'll have questions and we can have an interesting discussion. So with that, let me just thank you for inviting me to Laboratory Medicine Grand Rounds.
And there is time for questions. I see there are many of us.
So that pie chart you showed, which I think is probably sort of one of the
Yeah, let me go back to it.
mental things that you have to look at, and how did Dr. Schroeder assign the size of these pie slices?
Yeah, well, what Dr. Schroeder did was look at the data generated by Dr. McGinnis in an article in a study that was published, and I can get you all this citation. I should have added it to this, called The Actual Causes of Death, and I think the date of that was something like in the mid-90s. That's been updated, however, just in the past few years. And it's a great question on the basis of what he based these pie slices on. Where did he generate these figures? I wish I could answer that in more detail. The scuttlebutt, if you're interested in the scuttlebutt, is that there is plenty of debate about what lies behind these numbers. But what the point of putting this up primarily for me, for my purposes in this talk with you all, was to demonstrate that healthcare is a relatively minor determinant of health. So we get asked, well, what goes into that? But the other thing we could do to make that point is simply look at a number of countries that have cradle-to-grave healthcare with very steep social gradients in health. So even if we could imagine a world, a United States in which all persons, everyone living in the United States had really good, quality, timely health care. If we are like our peer nations, peers in other respects, we can bet that we're going to have steep social gradients and some measures of health.
I'm surprised the genetic predisposition is so large, and social circumstances is relatively small, I would have guessed.
Right.
The behavioral patterns, I totally believe if that could be.
Right. Yeah, they're hugely important to the onset and the progression of chronic diseases. And just to speak to your point, and I should have put this one up, although the origins of it are even less well known to me, so I felt a bit unsure about adding it to the slide deck. I have seen a different pie chart that puts genetic predisposition, and it's actually not even genetic predisposition, it's genes and biology is the meat of it, and it's something like 15%, 10 to 15%. And social circumstances, and there, it depends on how you define these things, right? So social circumstances, environmental exposure, their social circumstances must just be really broad, but I've seen that comprise up to 55% of these pie charts. And then there's another very interesting question about what behavioral patterns are, because not only is there a social gradient in health, there's a social gradient in health behaviors. Okay, so how are we to interpret that? If in fact it is the case that better off people, more advantaged people, people with more income, education, in occupations that are more prestigious, engage in healthier behaviors, while less advantaged people do the opposite, engage in more sedentariness, poor diet, smoking, etc. By the way, smoking, we've seen that trend reverse. We could talk about why that is. Is it then not a social phenomenon, or is it? I mean, if health behaviors are structurally patterned, are they then also really socially determined? Are they a social determinant of health? It's this debate about whether we consider those sorts of behaviors free and informed, right? And thus where to locate responsibility. Do we locate responsibility with the individuals smoking? well, they're addicted by now. Maybe they started when they were 14, right? It gets complicated. Anyway, I appreciate you taking us back here. Yes?
I was recently reading something that asserted that geographical disparities in health actually trumped social disparities in health. Specifically, amongst those people who live at the southern end of the Mississippi River, the upper classes had worse health outcomes than people in the lower classes who lived at the northern end of the Mississippi River.
That's fascinating. Where'd you read that?
Enlightening to think about whether geographical disparities in health are just or unjust.
Well, right, and so, but what does geography capture? What might geography capture? A lot of social characteristics and factors, right? I mean, we could also say, I mean, I don't know if you all are aware of an Institute of Medicine report that was published in January of 2013, penned by Stephen Wolfe, that it's titled, let's see, it's titled Poorer Health, Shorter Lives, the U.S. Health Disadvantage. Our best off Americans are worse off than those best off people in our peer nations. So, you know, Japan and all the Scandinavian countries and the Western European nations, peer nations, some 16 or 17 of them, even our best off people appear to have worse health outcomes than our best off people. So I'm just speaking to your point about geography, right? But what does, you know, in the 8 chapters they devote to trying to unpack what's going on with that, they are social determinants. It relates to our healthcare system, our public health system, income inequality. You know, I mean, these are speculative at this point because they're still trying to figure it out. It's a puzzle. But they're very much social determinants that are operative there in those geographic differences. I don't mean to squash your point. I think it's a great point. Yes, hi.
That just reminds me of something really quick. There was another medicine grand round speaker several years ago who spoke about that question. He actually looked at income disparities and geographic disparities, both all countries on earth and then within the counties of the United States. And it wasn't, there was some relationship to the wealth of a particular area to health, but also the disparity in wealth. So the difference between the top quintile and the bottom quintile was, you know, if that was a very large number, then even the rich people there did worse than, say, the richest people who may have been poor in a place where there was a less of a poor to rich difference.
Yeah, I think what you're referring to is the income inequality hypothesis, which is this idea that income inequality is a characteristic of a region, whether it be an entire country or a county or a state, where that exists. And this was contentious for quite some time, but in the last few years, this has gotten much clearer and much more certain that it is, in fact, a contributor to poor health and to social inequalities in health.
I did actually have an question, though, too.
Yeah.
So I was drawn to this pie chart, too, merely to look at it to say, what are the things that we can do something about? And was sort of disheartened by maybe how frustratingly difficult it can be. One of the things was the behavioral patterns being large there. I was reminded of the old adage, you can take a horse to water, but you can't make it drink. And so, you know, we can give or do lipid testing, so cholesterol testing, but we can't necessarily force someone to take their cholesterol medication at home. As we're moving towards more community-funded healthcare in this country and as it exists in other countries, I'm wondering, you know, what is the ethicist's thoughts on the balance between providing healthcare services to people and, on the other hand, forcing them to actually use them, to actually get better by them? Is it fair to, you know, if a society, we all decide that we want to increase outcomes, that we're going to provide testing or therapy, that do we merely have to just offer it? Do we need to incentivize it? Or can we force it in some way, either financially or, you know, we force some things. We force tuberculosis therapy on people, but we don't force, you know, we don't actually have police come and take cigarettes away from people. So what is the ethicist's sort of thoughts about how fair it is to force or suggest or not at all suggest that people actually accept the health care that they may be getting?
Right. So it's a great question. It's actually a question I spend a whole lot of time writing about and teaching about. It's really the health responsibility debate. It's a piece of that. And how we should think about what are, you know, the role of incentives, carrots and sticks, right, rewards and penalties, and trying to encourage people to take up services that are increasingly, we hope, made available to them. This ethicist take on that is complicated and many-pronged, but I generally am not in favor of sticks, penalties. I think rewards, when modest, if we follow the lead of Germany and some other countries, might make a difference, might encourage people to take better care of themselves, to show up to their appointments, to take their medication and that kind of thing. But let's think about what's behind the behavioral patterns, right? It might be some very reasoned choice that I really like potato chips and I like watching TV and I'm going to do those things together. It could be that, but we can also take a look at the lives of people who are stressed chronically by their socioeconomic circumstances, by perhaps daily assaults and insults related to race or gender or whatever. You know, the mother of 2 children or 3 children or whatever who makes the choice to go to McDonald's to get a hamburger or 4 or however many they need might be making a quite prudent decision that day, right? Because for $5 or $10, she could be deciding to satisfy her children, satisfy herself, fill their bellies, and yes, it's not a healthy choice. Is it a prudent choice? Maybe. Is it a choice we'd call full of options? No, because 2 to 1, she doesn't got a lot of options. She doesn't got a lot of time, she doesn't got a lot of money, and who knows what her neighborhood looks like. I don't know if you've been in a poor neighborhood lately, but it's filled with fast food restaurants. And places selling healthy fresh foods are far less available. So I guess I would be inclined to say that those incentive programs should be reward-based, and they should not only just reward the taking of the medication or the showing up at the appointment on time, but they ought to work also on the social environment that conduces to poor health behaviors, right? We ought to work upstream. Now, I'm not saying only upstream. We can work upstream while we're working downstream. But to do otherwise strikes me as simply unfair to people who are already kind of struggling to get the tasks done in the day, right? So that's this ethicist's take on that question. Yes, hi.
What do you make of advertising, especially the advertising that fosters bad or unhealthy behavioral patterns, which accounts for the vast majority? Is that just?
Well, I think you've asked a great question. And, you know, cereal makers should be ashamed of themselves because this has been studied. This has been studied. Their advertising quite intentionally targets children with misinformation to misinform and to manipulate. They put the cereal boxes down low where the kids can see it. And yeah, so I think, you know, but I mean, I do see change on that front. I do see that you begin to see big food makers come out with, you know, healthier products and promises to, you know, not advertise. But I also think that government regulations would be just fine if during those hours when many children are stuck before a television to watch whatever, we didn't allow certain types of advertising. It is government intrusion, it is a government regulation, but I'm not sure I see the harm. The cereal market is doing just fine.
That's actually an interesting point because there's actually an income disparity here also, because if you can't afford cable TV or Netflix or something like that, then what you watch involves lots of advertising, whereas, you know, I've got a 5-year-old who watches Netflix all day and watches junky stuff on Netflix, but he doesn't see ads.
Right.
So he doesn't know about all this stuff.
Yeah, it's a great point. It is a great point. Thanks for bringing it up. And I'm just realizing I haven't been repeating your excellent questions. Jessica's been waving at me back there, and I've just been ignoring her. Please forgive me. But the point was made that this reflects an income disparity, right? I mean, I don't know. How many of you watch television that has advertisements anymore? Probably not many of you. I don't know. I haven't. because I can't stand them. And if I had kids now, I would never let them see advertising. Because we don't have to. Yes.
I'm looking at this and I hear people say behavioral patterns, and immediately they talk about they don't take their medicine, they don't go for checkups, all the things that don't encourage good health. But behavioral patterns goes both ways. There are the people who exercise properly, eat properly, et cetera, et cetera. But even those people, according to this pie chart, have a 30% predisposition to a genetic disease.
Yeah.
And I don't know exactly where I'm going with all of this, but social circumstances, 15%, well, we all think the poor person who's in the poorest neighborhood. But of that 15%, there's a bunch of people who's in the upper class, I'll put it in those kind of terms. And I'm not exactly sure where I'm going with this, except that everybody assumed that you see behavioral patterns and that's a negative word, whether it could be a very
Sure. So one thing that's really important about what you're bringing out is that these are generic, right? I mean, social circumstances can be good circumstances or bad circumstances. Behavioral patterns can be good or they can be bad for your health. We can have access to health care or we can have no access to health care, right? The kind of environment we live in, right? Whether there's the quality of our air, the quality of how much noise pollution, whether we're likely to get asthma because of the neighborhood we live in or whatever. Environmental exposures, right? But it could be that we live in some pristine place where we're not subject to any sort of toxins. So your point is a good one. The social determinants of health can work both ways, and when those social determinants are chock full of chronic deprivation and adversity, by whatever form, socioeconomic status, race, gender, et cetera, and so on, then this is where it goes poorly for people, when it goes badly for people's health. So I'm not sure I knew your question, but I think it's a fine point to make. Yeah?
When trying to think about distributing health fairly and equally, I'm trying to tease out the subjective health from the objective health, where two people who have exactly the same disease can feel, one person can feel they're actually, like a man who breaks his hip actually comes to work, comes to work every day versus somebody else who would be bedridden for months. There's a real difference in the subjective perspective of their health. How do you deal with that when you're thinking about the distribution of health? How do you actually, just this pie chart, constructing that, you'd have to have some measure of health. How do you tease all that apart?
Right. So, I sort of glossed over something that's really complicated. I didn't talk much about what I meant by health other than to say, a life free of preventable morbidity and premature mortality. But it's really complicated. At least one chapter of my dissertation so long ago was devoted to the meaning of health. And the conclusion I came to was that the definition of health depends on the context in which you're defining it, right? You read report after report and there's just so much variation. The interesting thing about the subjective sense of health is that my understanding is, and I think this is based on good evidence, that people's self-reported health actually correlates pretty well with objective measures of health. In fact, Michael Marmot, in his book, if you haven't read this book and you're really interested in these phenomena, a book called The Status Syndrome, came out in 2004 or 2005, he talks about how in order to get the best measure of health, you actually have to include both objective measures and subjective measures of health. But nonetheless, I take your point. Our sense of health is widely variable. You take the same affliction or the same broken bone or the same whatever, and people will respond to it very differently. Fortunately, at the level I'm working at, we can sort of choose certain health outcomes or health indicators and sort of swing with those.
So asking when somebody has so much stress in their lives, just trying to meet the daily needs, on average, do they have a poor perspective subjectively again of the same? Is that?
Oh, that's a good question. Do they? Well, so a couple of responses to that. So Amartya Sen, does that name ring any bells in the room? So he's a Nobel Prize-winning economist and philosopher, and a philosopher, a moral philosopher by the name of Martha Nussbaum, pioneered an approach to social justice called the capability approach. Actually, I have it right here. You will see, I couldn't labor the point, but the means necessary for the exercise of capability is essential to flourishing. But anyway, as an economist, he's done a number of studies, and much of his work was done abroad, and much of it was done in India. He himself is Indian. And he came across this very interesting phenomenon wherein if you asked Indian men about their sense of health, they generally would report a much lower sense of health than would women. Yet if you took objective measures of their health, women, and so women would say they were healthier. So, sorry, I don't know if I completed my thought. Women would generally rate their health higher than did the men, okay? But if you took objective measures of men's and women's health, the women were much worse off, typically, than the men. Now, why would this be in India? Social structure. And tell me more what you mean by that. Oh, and I'm just realizing we're over time, so you were gonna, sorry, Mark.
Last question.
So let me just make this point, because it's actually social structure. So what do we know about the average life of a woman in India, at least when Amartya Sen was doing this work? It wasn't a very good life. I mean, it wasn't like women had, full freedoms. Despite democratic reforms, the life of women in India is that of an oppressed minority. And what he noticed, and it's actually essential to a capabilities approach, is that if we internalize oppressive norms, since that we don't deserve much, our second-class citizenship, then we don't expect much. And thus, even a not so well-off life, a moderate to low health, we will judge to be adequate, if not good. And I could tell you how that relates to a capability theory of justice, but I won't because we're out of time.